So in this last chapter, since I don't have an audio guide, I'll be the audio guide here as I provide you with this video feed. So what the author does, I think, just really well is just capture some of the health conditions that you have either learned about, and some of these may be newer to you, and to take for them really some treatment approaches that you can apply as a PTA when you're working with these various populations, and just is kind of like really reflective of the Guide to Practice, but here you have something more prescriptive in terms of some general ideas to help these individual patients, as long as they're under general categories within the PT plan of care, which is related to strengthening and related to restoration of function. But it's important to know about some of these conditions because you can't go in there with blindfolds on and not realizing the importance of just the cannot, I think, in any way diminish the value of taking a vital sign during treatment, particularly when you are increasing the load of activity because of these different systemic changes that occur in the elderly. Now, I always caution that you do not want to characterize the elderly as a group of people and think you have to follow the prescriptive steps with every elderly patient who walks in your door and whip out the blood pressure cuff and take O2 sats. That is ridiculous. There's no need to be checking O2 sats on somebody who does not have a cardiopulmonary problem and who has not presented with any health risk or problem that would be a catalyst to check O2 sats. Now, as far as checking someone's blood pressure after they do a strenuous activity, unless it's contraindicated because of perhaps they're on a beta blocker, or you may not get an accurate reading, or it may not represent what's actually happening to them systemically because of the drug reactions to our vasodilators, dilators, and certainly to what's happening in terms of what you're measuring in that vital sign. Blood pressure is one of the best means that you can extrapolate to kind of get an understanding of what's happening systemically with that individual patient. One of the things that I think is important, especially when working with the more frail older adults, is before you get that person standing up and after they kind of go through maybe a rough bed mobility activity. When I say rough, it just means that it's a lot of work. It's not that you're physically rough, or it's just a lot of work. And their RPE is up to maybe 14 or 15 just to that activity. Before you stand them up, you kind of want to get a good sense of what that blood pressure is, especially if it's been, something that's going to increase that load or demand on the cardiopulmonary system, and the vascular system, and the musculoskeletal system, and the neurological system, to see what kind of response has been produced. If you have somebody that you think should be fine and ready to go, even though they have this higher RPE, you slip that blood pressure cuff on them and they're like, whoa, you're down to 60/30. That's not normal. Let's hang out for a little while. So I think that's what I think is important and critically important, is that you recognize the value of checking a vital sign, and that could be just counting respirations too, if someone is showing signs of really struggling to get air, and then at that time doing an intervention to help them breathe, whether that's breathing exercises or, in that case, slapping on the oximeter to see what their O2 sats are. That may be time to get nursing involved if their O2 sats have tanked and are not recovering, to provide some supplemental oxygen. So, and it's important to know kind of the signs and symptoms of septicemia, which, blood pressure decrease is one of those common. Not that we're going to ever say to our patient, I think maybe you have some septicemia. But if things aren't adding up, and they could be having a systemic response to fighting an infection, which is what septicemia is, the toxicity of the system. It can be localized or it can be systemic. And then we have just a brief conversation on Alzheimer's. We're going to talk more about that later on this term, but just knowing, what the nature of Alzheimer's is, and know, certainly that there's different types of memory loss too. It's not just Alzheimer's. That's actually not the majority. The majority in terms of dementia, if we're looking at dementia as a health condition, that is not the number one type of dementia, actually. There's several different types of dementias. And just kind of learning some ways of how to use some effective treatments. I'm introducing you to the SLUMS, St. Louis University mental exam. This is something that PTA can administer. Generally, if we're working in a team, the OT has already administered this, or possibly the speech-language pathologist. But certainly, if you're working in an outpatient clinic without ancillary staff or interprofessionals working with you with that particular patient, you can do a screen, and it can be actually very interesting. So, you're wondering why their patient isn't doing their exercise, and they say they forgot. So maybe there's a reason they forgot, perhaps because they have just really poor recall, and that's what the SLUMS is a very good tool for. And I would get familiar with it, and maybe out in clinic just practice with it with a coworker. The important thing with any tool, you want to be delivering it consistently. You don't want to shorten sentences and say, like, for example, please remember these 5 objects. I'll ask you what they are later, and then start changing them, saying orange, pencil, socks, apartment, truck. No, you need to be using a consistent screening tool. You can't just be making these things up and changing them. These are standard instruments, and that's really important. You may think that's not necessary that I bring that up, but I have seen clinicians make this stuff up, and I'm like, what are you doing? They're like, well, this is a tool. I can change it around. No, you can't, because that's going to throw off your whole score, and it's like doing a balance test and just making it up as you go along and thinking you're getting a valid score. It has to be consistent, and you really need to be delivering this information in a way that the person can hear you and that they at least have an understanding of the question, but you can't guide them and help them answer the questions either, which is what a lot of people want to do because we want to be helpers. So you really need to be skilled in using this instrument before you start using it. And then the results can be really indicative, and we'll talk about much more later about how you share with somebody what their score is in a person-first sort of way. So you have guides and tools of some ways that we can help different populations. The evidence is still out that physical therapy can be an effective intervention for osteoarthritis, that we can help people who don't want to have knee replacements to have longer quality, better quality life and have opportunities to continue to use their joints. And we also certainly have evidence that we can help people before they have knee replacements in terms of effective physical therapy. But it can't just be stuff. It has to be real specific, and that's important in terms of exercise interventions. And then some tips on how to help these other problems too, and how physical therapy can be quite useful.